Good morning, everyone. Welcome. Today, we're going to have a clinical masterclass on a very critical topic in orthopedics, chronic osteomyelitis. We'll go through the exact history, the examination, and the management plan you need to master for your ward rounds, your final exams, and of course, for your OSCEs. So, this is how we'll proceed. We'll start by understanding why we call this a fight for the limb. Then, we'll dive into the anatomy of the infection itself, move on to the clinical investigation and how you confirm your diagnosis, then outline the definitive 4-step cure, and finally, we'll put it all together in an OSCE masterclass so you can present your case flawlessly. So, Section 1, the fight for the limb. Now, I use this title very deliberately because it frames the entire clinical challenge. Let's break down exactly why a precise approach is the only way to save your patient's limb and their function. You see, this slide shows the two paths a patient can take. It all starts with inadequately treated acute osteomyelitis or an open fracture. From this point, the path divides. The red path, this is the path of mismanagement. A delayed diagnosis, the wrong antibiotics, improper surgery, it leads straight to recurrence and, tragically, to amputation. But the green path, that's the one we're learning today. This is the precise clinical approach. This path leads to complete eradication of the infection and limb salvage. Your history, your examination, your structured plan, these are the only things standing between your patient and a permanent disability.
Now, let's move to Section 2. To win this fight, you absolutely must know the enemy. We're going to look at the anatomy of the infection and identify the 3 key pathological players you have to know by name: the sequestrum, the involucrum, and the sinus tract.
Think of this as the battlefield inside the bone. Right at the center, you have the sequestrum. This is a piece of dead avascular bone. Because it has no blood supply, systemic antibiotics cannot reach it. This means it must be surgically removed. The body then tries to wall it off by forming an involucrum, which is this thick shell of new, reactive bone you see all around it. And finally, the sinus tract. This acts like a pressure release valve, draining pus and tiny bony chips to the surface. If you see a sinus, you can be almost certain there is an active sequestrum hiding underneath. Now, this table is absolutely crucial for your understanding. Let's break down the key differences. A sequestrum is dead bone. An involucrum is new, living bone. Clinically, when you probe a sinus, the sequestrum feels hard and is often movable deep inside. The involucrum, on the other hand, is the hard, irregular thickening you can actually feel under the skin. On an X-ray, the sequestrum appears dense and white, while the involucrum is the reactive new bone forming around it. But here is the most important clinical point. The sequestrum is the enemy. It has to be removed. The involucrum is your ally. It provides structural support, and we preserve it whenever possible.
So we understand the pathology. Now, how do we find it? In Section 3, we begin our clinical investigation. We start by gathering all the clues through a systematic history and a very, very thorough physical examination.
A focused history is paramount. You must ask about a previous open fracture or acute osteomyelitis. This establishes the route of inoculation. Ask about the sinus discharge. Is it intermittent, which suggests a temporarily blocked sequestrum, or is it continuous? The nature of the pain is a key clue. A dull, aching pain that gets worse at night points to deep medullary tension. And of course, ask about the discharge itself. Foul-smelling pus with visible bony chips is the absolute hallmark of an active sequestrum. And please don't forget constitutional symptoms like fever and weight loss, and always assess risk factors like diabetes or prior antibiotic use, because this will alter your management threshold.
After the history comes inspection. First, always expose the limb fully and compare it with the opposite side. Look for puckered skin, sinuses. Very often, there are multiple. Check for active discharge. Is it pus or is it a serous fluid? Sometimes you might even see exposed bone, the sequestrum itself, visible at the surface. You must note any limb deformity, like shortening, and look for evidence of chronicity, things like significant muscle wasting and old surgical scars. Now, it's time for the hands-on examination. You will feel for tenderness directly over the bone and check for any localized warmth. You will palpate for that irregular bony thickening that confirms the involucrum. If the sinus is near a joint, you must assess for stiffness. And critically, never forget the neurovascular status. A full check of the distal pulses, sensation, and motor power is absolutely mandatory to rule out any advanced complications.
All right, let's move on to Section 4. Now that we've gathered our clinical clues, it's time to confirm the culprit. We'll focus on the definitive special test and the investigations we need to absolutely prove the diagnosis and plan our attack.
This is the definitive clinical test, the Sequestrum sign. In your OSCE, you must demonstrate this. Using a sterile probe, you gently navigate down the sinus tract. The sign is positive when your probe makes direct contact with a hard, gritty, and often movable piece of bone deep inside that tract. This tactile feedback is unmistakable, and it confirms the presence of retained dead bone that requires surgical extraction. There is no clearer clinical sign that surgery is needed. Your clinical findings are then confirmed with investigations. On an X-ray, you're looking for that dense sequestrum and the surrounding involucrum. For advanced mapping, an MRI or a sinogram where we inject dye into the tract to visualize it helps us map the full extent of the infection and any hidden abscesses. Bioclinically, inflammatory markers like ESR and CRP will be raised. And here is the mandatory prerequisite, a deep pus culture and sensitivity test. This must be obtained directly from the deep tract before starting any new antibiotic therapy. This is to ensure you are targeting the correct organism.
All right, now for Section 5. We have our diagnosis confirmed. It's time for the cure. We will now walk through the definitive 4-step surgical and medical management plan that is designed for complete eradication of the infection. Management follows a very logical 4-step path to eradication. Step 1 is pathogen identification. You must get that deep pus culture first. Step 2 is a conservative bridge. Based on that culture, the patient receives 4 to 6 weeks of targeted antibiotics and aggressive local wound care. But the only cure is Step 3, definitive surgery. This involves a radical sequestrectomy, removing all the dead bone, and a complete debridement of all infected tissue. And finally, Step 4 is managing the resulting dead space, which might involve antibiotic beads or more complex reconstructive procedures for large defects. And now for our final section, the OSCE Masterclass. This is where we will synthesize everything we have learned into a perfect, concise, and high-scoring presentation that is sure to impress your examiners. So here is the ideal presentation. Please practice this flow. You would say, this 35-year-old male presents with a persistent sinus discharge over the tibia for 2 years, following an open fracture. On examination, there is a puckered sinus with seropurulent discharge and a palpable sequestrum. Radiographic imaging confirms the presence of both a sequestrum and an involucrum. My provisional diagnosis is chronic osteomyelitis of the tibia. I would confirm the pathogen with a deep culture and plan for a surgical sequestrectomy and debridement. You see how that perfectly synthesizes the history, examination, key findings, and the management plan. It's concise, and it is flawless.
Now, to ensure you score top marks, let's contrast the fatal mistakes with the pro tips. Never suggest treating a confirmed sequestrum with antibiotics alone. Never fail to probe for a sequestrum during your examination, and never prescribe antibiotics before you get a deep culture. Instead, for the pro tips, consciously show the examiner that you are looking for both the sequestrum and the involucrum. State confidently that surgery is the definitive cure, and a key tip for our Indian clinical context, always state that you would screen for tuberculosis when presenting any case with a chronic sinus. And that completes our deep dive into chronic osteomyelitis. The path from competence to mastery is practice. Please apply this structured approach to every single sinus case you encounter on the ward. I'll leave you with a question to think about. With the global rise of antibiotic resistance, how will the management of this ancient disease evolve in the next decade? Thank you for your attention. If this explainer was helpful, do let us know in the comments below.